than 80 millimeter, etc. The instance of thin endometrium is around 38 to 66 during stimulation cycle, and or 1 to 25 cycles. And part of the reason is intrauterine synechial Ashman syndrome and surgery, fibroid, radiation, infection, etc. And but this, because from so many years, the statistic couldn't find the difference between thin endometrium and thick endometrium. No conclusion yet. And so mostly we use transvaginal ultrasound to check, but if you can do repeatedly, it would be more accurate. So for stimulation cycle, if we found this thin endometrium, better offer patient a consultation, telling them the outcome may be no good. But from this review guideline, there is found insufficient evidence to recommend change stimulation can improve the endometrial thickness, or insufficient evidence said you put in the adjuvant therapy can make it better. And so in IVF fresh cycles, less than 8 millimeter, you should tell the patient might be negative impact. And for frozen cycles less than 7 millimeter, we should be careful. And they don't support natural cycle or HIT cycles, and they don't support to give aspirin. They don't support to give luteal estradiol, and they don't support use Viagra and or infuse GCSF or give pentoxifidine or HCG or gonadal GnRH agonist, platelet-rich plasma, stem cell, etc. So far, we don't have evidence, strong evidence, to support all these adjuvants. But the authors suggest, the review suggests that we should use hysteroscopy or HSG, histogram, to confirm there is no adhesion inside. So conclusion is, thin endometrium is infrequent but challenging in assisted reproduction. But we have to think balancedly for the thin endometrium and also other alternative treatments. So far, there is minimal evidence to support any specific protocol or adjuvant to thin endometrium. So my question is there any pathologic defects for thin endometrium apart from like adhesion, fibroid, etc.? This is the, I noticed this kind of the published before. They mentioned this one use ultrasound and MRI to check the young girls' endometrial volume and their endometrial uterine volume and endometrial thickness. Then they also check with the breast stage, Tanner classification B1 to B5, and they found the uterine volume and endometrial thickness are positively correlated with pubertal stage. Once you grow mature, you have bigger uterus, you have thicker endometrium. And also these two volume and thickness also related to large follicle numbers and also estradiol levels. So once you have efficient ovulation, your body estradiol level is high, consistently high, you grow mature, maybe your uterus can grow bigger, and the endometrial thickness is thicker. So sometimes we met PCO patients maybe their period come 3 or 4 times a year. So the uterus is lack of stimulation, then it becomes shrink. This is the theory. So both the abdomen ultrasound or MRI assessment, uterus volume and endometrium are strongly correlated. This is the picture, and we can see the endometrium B1, 2, 3, 4, 5. This is the breast stage. The bigger, the maturer. So we can see the endometrium on MRI at 1, 4, 5, 5, and the medium is 9. So grow is the breast stage, and also the E2 level also positively correlated. And the volume 2.3, 6.2, 9.6, and 23.3. This is all positively correlated. Then this is another article sharing the polycystic ovary syndrome patients, the endometrial thickness and the uterine volume. They checked the over 1,000 PCO patients and with 182 health control. And they also checked the blood test for the endocrine metabolic characteristics. They found the uterine volume progressively increased with age in PCO patients. The way they check the volume is like a length, width, thickness for the ovary and also for the uterus too. And PCO, they define more than 12 follicles, each follicle measuring 2 to 9 millimeters. The conclusion is uterine volume increased progressively with age and both obesity in PCO patients. The smaller uterine volume and the endometrial thickness in classic PCOS phenotype might be more severe, might be attributed by severe hypoandrogen of these patients, HA. Now we can see this is PCO patients, this is control. We see the uterine volume, but no statistic difference. And then endometrium thickness is almost same. And but for a small uterus, can we change it? Can we make it bigger? This is another thought from POF patients. POF patients, they don't have steroid stimulation. Then if they don't have period, if you don't give HRT, finally the uterus will become small and the endometrium is thin. So this one, they compared a different way to give HRT and the response of uterine volume and endometrial thickness, blood flow, etc. Then there are 2 ways of HRT. One is psychological, one is standard. And the psychological HRT, they use transdermal estradiol and vaginal progesterone. And the standard HRT is the composition is just like oral pills. And results found that the psychological HRT have better results. So actually, this kind of small uterine volume maybe can grow after you give HRT. Now we can see the endometrial thickness Turner cancer idiopathic. Like from endometrial thickness, the mean level is like 1.7, 1.8, 2.6. We can see they're quite low. Volume also 10.2, 10.1, 23.1, and all is this is mean level. Then we can see the uterine volume and the endometrial thickness also correlated together. Then this is the response to HRT. This is psychological and the standard. Then we can see the psychological thickness, the group thickness is thicker than the standard HRT. Also does with uterine volume. And but early to 2010, some paper mentioned about the uterine size, but the uterine size at the beginning in those years, people don't mention much about the uterine volume related to pregnancy outcome. Mostly just mentioned about uterine length. I remember 3 or 4 years ago, I went to Germany, joined a actual campus meeting, education campus meeting. Some author, they mentioned about, they asked the audience a question, do you know how big the intrauterine volume cavity is? Actually, they mentioned is 1.5 cubic centimeter, the actual functional intrauterine space. So this is from Nagoya, Japan. They mentioned 42 patients with biconate or septate uterus and 1,528 patients with normal control. And they calculated the cumulus successful rate of birth, abdominal chromosome karyotype, and also the DC ratio. DC ratio is the septum length divided the resting uterine length. And they found during these patients, 3.2% have congenital uterine anomalies. And but this 42 biconate patient, among them, 59.5% had a successful first pregnancy after examination. Didn't do anything, so still can have a successful pregnancy, but expected. Then the normal control have 71.7% have successful pregnancy, so higher, but no difference in live birth rate. And in normal uterus, the abortus, the chromosome karyotype, have higher abnormal rate. And the DC ratio can predict the ongoing in miscarriage group have a greater DC ratio than the live birth group. And so the author's conclusion is the congenital uterine anomalies have negative impact on reproductive outcome. Couples with recurrent miscarriage and uterine anomalies are associated with further miscarriage but with normal embryonic karyotype. The DC ratio has a predictive value for further miscarriage in recurrent case. This is the characteristic of the patients. We can see they are same age and miscarriage time percentage is same. And we can see with anomaly, the 59.5 patient, they tried the first after the examination, they got first successful pregnancy, comparing 71.7, but the difference is not significant. And then someone mentioned about the length of the uterus and the position of the uterus, whether it will affect the pregnancy outcome. Then 800 patients, they apparently normal uterus after hysteroscopy and HSG and pelvic ultrasound. Pre-treatment, they did the mock transfer, that they found the uterine cavity. They divide 3 groups. First group is less than 7 centimeter, 7.8 centimeter, and greater 7.9 centimeter, greater than 9 centimeter. The 3 groups. They found retroverted in 38.2%. Almost 40% women have retroverted uterus. They also found old and para women have bigger uterus, but the difference is not significant. And this is the study group 2, anteverted and retroverted. And the 3 groups, the pregnancy outcome, you can see the fertilization rate, cleavage rate are compatible. But this is the clinical pregnancy rate. This is 36.7. This is 46.5. And the group 3 drop again. Once the uterus bigger, drop to 32.9. And the ectopy rate, this is significant different. So group 2, the length between 7 to 9 centimeter has lowest ectopic, lower ectopic rate. This is significant. And the great uterus, the bigger uterus is none. And sometimes the uterus size affects pregnancy rate. And also we have to watch out for the ectopy rate. And this is also this is Korean report. And they also divide 3 groups, less than 7 centimeter, between 7 to 8, greater 8. And they routinely transfer on day 2, but if come to holiday, we shift to day 1 or day 3. Then this is, we can see that in this study, they found the difference or significant. The small uterus, medium, are bigger than the And this is the human reproduction report. From they also divide. They think the uterine length smaller than 7, bigger than 9 centimeters were less likely to achieve live birth. And smaller than 6 centimeters likely to have spontaneous abortion. Then all the uterine length is by uterine sounding, and divided to less than 6 centimeters, 6 to 6.9, 7 to 7.9 centimeter. So many groups, 5 groups. The medium level is 7 centimeters, but positively correlated with BMI and fibroids. If you have fibroids, you have a bigger uterus. And small uterus group is almost half of the live birth rate expected as the normal group. So mostly the uterine size is around 7 centimeters by sounding. And then this is the curve. This is I surprisingly found that recently this paper is published by Chinese group in Hunan. I spent 6 years seeing patients there in Hunan. This hospital is next nearby. And they use ultrasound to check, so their distance is a little bit different, shorter than sounding. So, but the theory conclusion is similar. So if the small uterus will have a negative impact on pregnancy outcome. But how big is big? We just use the distance, the length. And also someone mentioned about the width, like this. The width is 27 millimeter, 2.7 centimeters wide. And also mostly the size of uterus prediction study they use for like IUD insertion. Like this is they mention about the total uterine size. The average is 64 millimeter. Cavity is 35. Sometimes you found the length, but you have longer cervix length, so the cavity actually is small. But someone have small cervix, for example, after colonization, but the cavity is okay. So we have to go inside to check carefully whether the cavity is big enough for a pregnancy to happen. This is my news report we did 8 years ago. So this treatment was carried out 10 years ago in Jiayi. This woman, I remember her AMH was very low, maybe less than 0.5. I did surgery. She said she wanted to take a rest. So that month I gave her Promed, and she got a spontaneous pregnancy with twin. So when they deliver, I already left the hospital. The husband come to me. So we did this to remind everybody the uterine size matters. This is recent story. We have a patient come to me, and this is during surgery. I was surprised that the uterus is so small, at the right 2 finger width of my. This is during surgery. They came at 38 years old, married 1 year, did 3 times IUI, and all told have thin endometrium. And irregular period found because her age and also this is myoma. A little bit worried about the location. She wants to cut it. So during the surgery, surprisingly found a so small uterus. And after 3 months after the mammectomy, we did hysteroscopy and sounding to 7 centimeters. We give her DHEA, OPU, and 6 oocyte. Then I did the expansion. Then put in the balloon, but unfortunately the balloon dropped out. For me, I have bad experience with balloon, so now I shift back to IUD. Then later we did FET with 3 day 3 embryo. But that time the endometrium is already 8.8 millimeter. Then she left to other hospital and come back in 8 months. And we give another 3 months DHA and OPU got 4 oocyte. At that time we checked hysteroscopy. The uterus is bigger, but found scar. Then another round of OPU got 5 oocyte. Finally, we used 4 cycle with 2 blastocysts singleton, and altogether have spent 3 years. Now she delivered successfully recently. This is the before the treatment when the first time hysteroscopy. I feel this is small. Most small part is here. Now this is the tubal orifice entrance area. From my experience, I think the most implantation happened here, this place. I did some hysteroscope examination during suction DNC, missed abortion patients. I go inside to check the implantation site of this abortus, and I have found none of the abortus implanted on the fundus. So fundus is clear, but mostly implanted at the side. If you have a chance, you can check where does the abortus implant. This is very interesting. And this is I did surgery. Most of the surgery just like septum resection. So try to make it here smaller space, push outside. And this is after the surgery. This is very difficult to say. This part will become flat. So the implantation side, when embryo grow won't touch the ceiling so easily. So give us space to grow. It's my theory. And another patient came at age of 39. This one not succeeded yet. Already married 10 years, and duration period bleeding only 4 days. No dysmenorrhea. Already did 7 times IUI. I don't know why she keep doing this. Then once did IVF, got 11 eggs and the embryo transfer 4. A pregnant Mr. Abortion with heartbeat. So the embryo maybe is okay. We did the hysteroscopy sounding to 6 centimeters, very short, and the metrium for biology sound only 5.6 millimeters. And after the expansion, we transferred 4 embryos, but without the chemical pregnancy, you have to send for the MTX injection. This is at the beginning of the treatment. We can see here it's quite narrow. Now here it's okay. Right side is a little bit better. This is not very clear because I did a hysteroscopy during OPU, so save patient another surgery. So the endometrium, the appearance is different from ordinary day before during follicular phase. Now we transfer 4 eggs, but chemical pregnancy. This is after expansion. This is already after expansion. You can see the fundus part is flat. And here we give more space. But unfortunately, we have scarring. This is the balloon dropout or scarring. And this side, this implantation side are already big enough. So what I'm concerned is here, the space here. If the space is less than a coagulation loop, our coagulation loop is around 1 centimeter diameter. So if you put here, you find it's just calculating a loop. This is too narrow. Now, so this is normal or arcuate. This is septic, this is biconic. Whatever shape the uterus is, we just need enough implantation space for the embryo to implant and grow at the beginning stage. So this part is very important. If it's not wide enough, better cut it. This is, I show you one patient. This is 40 years old, delivered 1. So it's the parous uterine cavity. You can see here is 1. Do you tell the difference? Here is wide. It's parous lumen. So wide, I can put all the loop in. So wide. Then another patient came at 34 years old, still have myoma, and regular period, duration 7 days. Everything is normal, but has 2 myoma, so we did the myomectomy. Then for dating after the surgery, well, we found only 6 centimeters, 6 millimeters thickness of the endometrium, and also suspected with arcuate uterus. So we did a hysteroscope and resect the septum. For IVF, got 15 oocyte. We transfer day 3 embryo, but failed the first time. Hysteroscope again and transfer 3 blastocysts and got a singleton. This is at the beginning. We only have 6.1 millimeters thick, and this is the beginning of the treatment. We see a little bit arcuate is coming out, protruding toward us. Then this is 1 month after the hysteroscope. We found that the fundus all flat. And here have bigger space. Comparing with this, with bigger space. People right side even better, like a parous uterus. And later, this is we use HRT cycle for frozen embryo transfer. We already can get 11 millimeters thick endometrium. And this is another patient, also not succeeded. When she came, it's already 42 years old, missed abortion for 5 times. When she came, she's taking Chinese medicine, heparin, because she was told, not heparin, aspirin, sorry, to have low proteinase. Also have diabetes, chromosome study is normal, but the cycle day is short. And IVF, we did blastocyst transfer, but at the age of 43, not succeed. This is beginning of the treatment. We can see the fundus is protruding to us, and both sides is narrow. This is at the beginning. This side is narrow. This is a little bit chaotic, is because during the OPU, we did hysteroscopy. We transfer the buses from the microscopic examination. You can see the embryo is not so bad, but she couldn't conceive. And I checked to date, she's already 45 years old. So difficult. Too late to find the problem. It's a pity. And but as I define this kind of surgery as uterine expansion. Actually, this is just kind of like a septum resection. Just the septum is very small. We just need 1 millimeter bigger space. That's all. That's what we need. And but we have different conclusions by other authors. This year published on human reproduction. Then they said uterine anomaly, the prevalence rate is around 0.2 to 2.3% in women with reproductive age. Currently, 2 classification systems worldwide, and with septic uterus, maybe risk of infertility, pregnancy loss, preterm delayed birth, and also fetal malpresentation during delivery. This is international multi-center survey. Totally, we have 151 women underwent septum resection, and also compared with 106 women has expected management. The median follow-up time is 46 months. And they included the centers from Poland, UK, and America. Very small, sorry. They found that the expected management and the surgery group, the live birth rate, cumulative live birth rate is almost same. And mostly have no significant. Pregnancy, conception, ongoing pregnancy, pregnancy loss, preterm labor, everything. Preterm birth, non-significant. And also, so this part is still controversial. So I mentioned this, hope you can use your expert to give me some feedback. Whether we should do it, maybe we need a large-scale study to test it, to see which direction we should go.
Thank you very much.